Hysterectomy, do you really need it, and what to know before surgery? I'm Dr. Durst, and I am a hormone specialist and sexual wellness expert. And today I wanted to deep dive into hysterectomy. I want to address the terminology of hysterectomies because that's changed over time, the stats on hysterectomy, what is the goal, what are the main reasons why we're having it, what kind of testing should precede it, and are there other things that can be done? And a top tip at the end, a tip that could actually maybe prevent you from having a hysterectomy. So we'll get into it. We've done previous videos on hysterectomies and we use the term partial or full. And then there were some comments about that maybe not being accurate. So I wanted to just address that the terminology has changed over time, and it's changed to the point where now it is a little more precise anatomically. But in the pre-2000 range, which is where I trained, and again, that just dates me, we basically were talking about hysterectomies as a uterus and cervix, and if they left the ovaries, that was a partial hysterectomy where they took the uterus and the cervix out, and a full hysterectomy back then meant they did the ovaries in addition to the uterus and the cervix. The cervix is the lower part of the uterus, and that's how that has been termed. Back then it was actually surgically, that's how we were doing notes. All of that was based on just the uterus and the cervix, and then the ovaries made it a full or a partial. But after the 2000s, and if somebody trained after the 2000s, they changed that a little bit because they started just taking out the uterus, and that's the goal of a hysterectomy, is take out the uterus. They would maintain the cervix, so it was called a supracervical partial hysterectomy because they weren't taking out the cervix as well. The terminology then changed to a full was a uterus and a cervix, and then the oophorectomy or bilateral oophorectomy, which was the ovarian removal, was separate. But we always clarify that in the office, but I think because the terminology has changed, I'm clarifying it on a video just so that you know. But we have those conversations because a lot of ladies don't understand. So when we say, did you have a full or partial, it's a, did they leave your ovaries or not? Because that's most of the women that are in that perimenopause, menopause. And again, when you're younger and you're having a hysterectomy, it actually becomes a bigger issue, period. But that terminology is just different. So the main purpose of the hysterectomy is taking out the uterus. And why is that? If we think, why are we taking out the uterus? It's mainly because you're having excessive bleeding for the most part, or something related to an excess in estrogen, really, because that causes division of tissue in the uterus. And so you'll have an increased endometrial lining, increased bleeding, and that's a pretty common phenomenon in that perimenopause timeframe. So if you're in perimenopause and your hormones are starting to be all over the place, a lot of times we have a drop in progesterone and testosterone. And when we have that, estrogen doesn't increase, but it actually looks a little more dominant during that perimenopause transition because it's not being balanced anymore by progesterone. So when that happens, a lot of women will have excessive bleeding and they will have ablations or hysterectomies during that time frame. And there is a tip at the end when we talk about what we can actually use to potentially prevent the effects of that estrogen dominance. But the goal is to take out the uterus. And now we almost term it an ovarian sparing or cervical sparing. And why is that? The ovaries, when we spare them, we're trying to maintain hormonal production, and the hormones being produced in women are progesterone, estrogen, testosterone. So we're trying to maintain that hormonal production. And then when we maintain the cervix, it's because we have found out that there can be some female sexual dysfunction that happens when we take out the cervix. So female sexual dysfunction, and sometimes they just have lack of pelvic floor stability and some bladder and urinary issues as well. So that's why we end up sparing the cervix or the ovaries. But if we think we're still cutting with the goal of taking out an organ, is there something that we can do to prevent us from having to cut? And so if we look at the main reasons for hysterectomies, is the most common gynecologic procedure. It's most commonly done for benign conditions. So conditions such as excessive bleeding, and It can be endometriosis or fibroids, but a lot of that still is the root cause is an excess in estrogen. So if we can actually just balance estrogen better, so what should we test before we actually do a hysterectomy? Well, we should consider hormonal testing. That should absolutely be in guidelines and not just recommended, but absolutely done before we actually cut. And cutting is just affecting tissue and things may not be normal after. And so if we can get away without surgery, we would want to test everything and potentially use something to prevent that surgery. And also when we cut or we have a hysterectomy, we're taking out the uterus, just know that the blood supply to the uterus and the ovaries is very tightly connected. There's two separate, but then there's also a branch to the ovaries off the uterine artery. So you can affect blood flow. And there are studies that significantly show that there's a reduction in hormones that are produced by the ovaries even when they are maintained with a hysterectomy. It is actually more predominantly affecting that 40 to 44-year-old range, and that is actually a very common age range for hysterectomies. So just know that hormone decline after hysterectomy, even if you're maintaining ovaries, happens, and it happens a lot, and there's studies support of that. And so if we can just think to the fact that we have an excess of bleeding or excess of estrogen causing effects, and we're cutting to prevent the effects or results of the excess estrogen, but we want to maintain ovarian production of the estrogen, can we not do something about balancing that estrogen instead of just going to the end result and taking out the organ effects of the estrogen? So what can we do? Well, most commonly in the guidelines, they are recommending you can do nonsteroidals, you can do tranexamic acid, but those are never getting at the root cause. The only thing that will get at the root cause is if you're balancing estrogen. So if you're doing progesterone testing and you're doing progesterone use, then you could potentially prevent the need for a hysterectomy. And ablation is another alternative to a hysterectomy. So they ablate the internal lining of the uterus so that you don't get that excess proliferation or division because of estrogen. So you're no longer getting that, but it's still not causing or correcting the root cause of it, which is excess estrogen. The only thing that really gets at that root cause is if you can use bioidentical progesterone to balance estrogen, and you need to do that in a time frame that is long enough that you can have some physiologic changes and reversal of that excess estrogen and potentially endometriosis, fibroids, or just an excess of endometrial lining. So those are things to think about. I want to know, so if you could just leave some comments, open up the conversations in the comments about, have you been recommended a hysterectomy based on excessive bleeding? What are the other reasons? Again, those cancer causing, then it's necessary, but most hysterectomies are done for benign causes that aren't related to cancers. And so I would love to hear if women are at that, and we get a lot of comments on an older hysterectomy video that we did, and that's why I wanted to do this video that just addresses some of the terminology change, but also I would love to hear what people are being told. Are they having their hormones checked before a hysterectomy? Are you given other alternatives? And why are they recommending a hysterectomy? So let's open those conversations. I want to hear what you're thinking, and let me know if you want to deep dive into this and talk more about progesterone, because we can do that. I'm willing to deep dive into anything.